All right, well, welcome back to Ultrasound Grand Rounds for this week and month and season, this new academic year. We're excited to be back. It is now September 2024. We were going to try to launch this a couple weeks ago, but things kind of got out of hand and schedules got a little bit wacky. And so we just delayed on to getting today, the first week in September. And we're pretty excited to be back. We had a good season last year where we talked about a number of interesting topics. In fact, I can't believe how many times when I'm talking to someone in conversation about something with ultrasound and say, hey, we talked about that. Go on back to that YouTube channel, look it up. It's in this playlist, and you can read a little bit more about what we talked about in Grand Rounds. So this is a great opportunity for us to continue on just learning more ultrasound. And I was thinking about it. We've been doing this for well over a decade. It's just been a staple of one of the things that we do with our ultrasound teaching here is just trying to provide high quality education for our residents, for our fellows, the medical students, and even for the faculty who join on with us. So welcome back. Great to be back here in the studio and just talking a little bit about more ultrasound. Just by way of an announcement, we're going to start a new series beginning next week, but we're going to go back to the basics and talk about some basic bedside ultrasound. And we talk about a lot of high-level topics. I was looking through some of the playlists that we have, and not a lot of talk about some of the the fundamentals of bedside ultrasound. So over the course of the next several weeks and months, we're going to go back to the basics and talk about some of the basic scans. And that's going to be a little bit what we're going to do going forward here. And then we'll also bring on some guests and talk about some other interesting topics. And the other big announcement is we are going to probably go to an every other week schedule. So today, obviously I can't be here next week for some family reasons. One of my kids is having a birthday. But then just with the time pressures that we're all under and the things that we have that we want to get done both here at home as well as with our other educational opportunities, I think we're going to go to an every other week schedule. Just give us more opportunity to bring higher quality lectures, and we're not just trying to just get something out for the sake of getting something out. So expect that coming up. The schedule will be a little bit different this year, but it should still be good, and we're going to still bring on some good speakers and have some good topics. So with that being said, let's dive on into today's topic. One of the things I like to do at the beginning of each semester, as it were, is to back up and get a little bit broader perspective. So not get into some, esoteric detail or some advanced thing, but to give us a broader perspective of what we're doing and why we're doing it. And so if you remember back, go kind of into the Wayback Machine, about 2 years ago, we did this lecture, 5 reasons why POCUS will make you a better doctor and save the world. Right? And yeah, it's a clickbaity title intentionally. But it was a way of talking a little bit about, 5 things that POCUS can do to kind of help you improve your clinical care of patients. And so today, with that perspective in mind, we are going to talk about 3 more reasons why POCUS will make you a better doctor and by proxy, save the world. Right. So just by way of review, though, last time we met when we talked about this, again, go back to the YouTube channel, look it up. It's about 2 years ago. 5 reasons why POCUS will make you a better doctor. Reason number 1 was that POCUS improves the physical exam. And we talked a little then about the history of medicine and how we get to the information that we get to make the decisions that we make. And so it's all about taking the patient and their complaints, understanding the symptoms and the signs, doing this exam, and ultimately, taking all that data, synthesizing it, and making a diagnosis so that we can then accurately understand what's going on with the patient, but then also treat the patient. And so we looked at how the powers of physical observation kind of morphed into what we now know is this ubiquitous utensil of medicine called the stethoscope, and how we've layered in and filtered in different lab values and different imaging techniques over the years, and how it's ultimately culminated with what we now know as point of care ultrasound, or POCUS, where we have the power to visualize inside the patient's body with this tool to get a better understanding of what's going on and how we can then use that to make faster diagnoses, more accurate diagnoses as we're attempting to manage the patient. So that's reason number 1. Reason number 2 in the previous lecture is that POCUS allows us to do a targeted assessment on certain structures, problems, patient presentations. And so we looked at this study about how POCUS, improves on the sensitivity and specificity of clinical exam as it pertains to skin and soft tissue infections. And another number of other applications where point-of-care ultrasound can help us look at a very targeted way at something going on inside the patient's body and make a better decision or better understanding of what's going on than what our physical exam can do alone, right? And so that's issue number 2. Number 3 is that point-of-care ultrasound, or POCUS, provides a better understanding of the patient's physiology. And I can't think of a better way or better place of describing this phenomenon in the whole cardiovascular area of point-of-care ultrasound. And that's why we've spent a ton of time doing cardiac ultrasound, doing pulmonary ultrasound, really to understand, because it's one of the more complex systems that we can deal with, is like this fluid dynamics has so many variables and so many inputs that when we pull one lever, it has an effect somewhere else. And where we'd historically have to kind of surmise what's going on or see what's going on clinically, now we have the ability to go under the hood, as it were, and see kind of what's actually happening at the LV level, at the RV level, at the atrial level, at the IVC level, at the aortic level, and really understand how all these systems work together and how pulling a lever somewhere can affect something else, down the line in the way that we want it to, or avoid, causing some clinical outcomes that we don't want to see happen for our patients. And so that's reason number 3. So number 1, improves the exam. Number 2, allows us a targeted assessment of certain areas. Number 3, it provides a better understanding of physiology. Number 4 that we talked about before is how point-of-care ultrasound saves time, right? And so we looked at a couple studies about how if you apply point-of-care ultrasound specifically in the pregnant population, the ED length of stay can be cut significantly. And this is something we see all the time, where we get these patients who come in with symptoms in their first trimester. And one of the things that we want to know is, does this patient have an intrauterine pregnancy? Yes or no, because that's one of the big questions that we need to answer. And if we do a bedside ultrasound, we can get there, we can interpret it, and we can have the disposition a lot more rapidly than if we had to, wait for conventional imaging. Not to say that there isn't a role for conventional imaging, but if there's something that all we need to know is IUP, we can get that answer a lot faster, and the studies show that. And so one of the benefits that we have with point-of-care ultrasound is that it saves us time, and then by proxy, we can increase our throughput in the department. So increased throughput means faster and more timely evaluation of other patients, maybe more critical patients. It also means higher turnover of the rooms, which is a positive impact for the system, and for the people that we serve, and just declutters things. And we know that increased time in the department, especially while boarding, waiting for a bed upstairs, can have a negative impact on patients' mortality. So anything we can do to help expedite the effective and the efficient workflow of patients through our department is going to have huge impacts on the work that we do down in the emergency department, right? So that's issue number 4. Remember, improves the exam, target assessment, better understanding of physiology, saves time. And the final and the penultimate reason that point-of-care ultrasound makes you a better physician and saves the world, that we talked about in the previous lecture, is that it improves our ability to do procedures. And so one of my colleagues, Dr. Sandy Werner, who's joining us today, she says if you can do a procedure blind, you can do it better with ultrasound. And I think as a general principle, that is 100% true. In fact, we did a lecture at the end of last season trying to advocate for this when it was challenged by some of our surgeons. And if you wanted to see a little bit of that dust up, go ahead and go back to the YouTube channel and watch why we think adding ultrasound to doing subclavian lines is better than just doing them alone, or doing them blind. So, but it improves the performance of procedures. And we'll talk a little bit about that today, but it's certainly something that we see routinely as an application of point-of-care ultrasound. So with that being said, that's a summary of the previous lecture that we gave about how ultrasound can improve your clinical practice. And today we're going to talk about 3 more. Now, before, I just have to say I've got no relevant disclosures to make, so we can kind of listen to all this. But then we're going to talk about 3 more reasons why point-of-care ultrasound will make you a better doctor. And I didn't put on the banner that saves the world, but ultimately, if we're better doctors, it saves the world. So at least that's what we like to think. But these 3 reasons it has better test characteristics, right? We're going to talk a little bit about that. It improves our ability to learn. right? Or, for me as a faculty side, it improves our ability to teach, and it also allows us to narrow the differential diagnosis or arrive at the diagnosis a lot faster, and then all the secondary and tertiary consequences of that rapidity in being able to make our decisions and understand what's going on. So let's talk a little bit about these three things, right? Number one, improved learning. And this begs the question, what is the most efficient way to learn, right? We're in back to school season. 3 of my myriad of children are now in school. So I have my youngest went to, or not my youngest, but my middle child went to kindergarten this year. So he is starting his educational journey. The other 2 are well on their way. And we are fully on into back to school mode right now. And so we're into this whole learning thing. And one of the goals of the school that we have, or that they go to, and I love this goal, is that they want to create kids who are lifelong learners, right? And that's the key. It's not just here's a whole bunch of data facts to pack into your head, but how can we teach you how to learn so that you can go throughout life and be successful in everything that you encounter, because you're constantly learning and adapting and developing and maturing and getting better, right? And so one of the things we want to answer is, what is the most efficient way to learn? The other area where this becomes certainly relevant is something else that we're doing right now at home, and that is training a couple dogs, right? So one of the big events that happened at my house this summer is we got a brand new puppy. You'll see him here. This is the Black Lab. He's almost 4. He's been with us for his life. But we added Scout, this new German short hair pointer, to our family this summer. It's created a lot of interesting energy in our home, a lot of things to do. But we get to start all over this whole teaching process of teaching this dog how to learn things, essentially. And so he's a smart dude. He knows how to sit. He knows how to go to his place board. He knows how to go in his kennel. He knows how to come back to me. I taught him how to stand still on command, things like that. And so all this happens through something that we call operant conditioning, right? And so if you go back to educational philosophy or educational theory, operant conditioning is a way of teaching behaviors to, in this situation, dogs, but also to us as educators and learners in medicine, how we teach these things to ourselves or to one another to basically learn how to go, execute a learned behavior and do it on a cue, right? And so as we break down this idea of operant conditioning, you identify, these basic steps. And this is what we had to do with my dog, right? And say, you identify the behavior that you want to teach him, to reinforce, right? And you try to isolate that behavior somehow, right? And then get that, in this situation, dog, to recognize that behavior, right? And then somehow reinforce that behavior, right? So that it becomes this loop, right? And then once they've learned that what behavior they want to do, how to isolate it, how to recognize it, that it's going to be reinforced, then they do it. Now we have to layer in this cue that will tell them to do the thing, right? And that's this. And when they've done that, then they've successfully learned this new behavior. And so, for me, one of the challenges, I've never taught a dog just to stand still on command before, right? And so it was challenging because I had to isolate when did he stand still, say that's what I want, reinforce that, and then layer in this whoa command so that when I say that, he'll stop, right? And it was fun because he does it now, and so that gave us the ability. It's basically kind of going through this process, right? This all happens, this idea of operant conditioning, based on 4 inputs, right? Either positive or negative, and either a punishment or reinforcement. And most of the time when I do this stuff with my dog, it's all in the context of positive reinforcement. There are certain behaviors that he exhibits that I don't like, right? And those need to be negatively reinforced, right? And so I can amplify the behavior that I want. I can squelch the behavior that I don't want, right? And I do this in the context of either giving praise or removing attention or removing praise, right? And so all of this happens in one of these 4 grids. Now, you can add in this whole element of there's positive punishment. So if you do something that you don't want, there's a negative thing, like a negative stimulus that's applied that you don't like. That's certainly a way. That's not what we're doing, particularly with our dog right now. But in the form of this grid, like these 4 ways of kind of reinforcing and developing this behavior. So take this whole educational philosophy, this whole educational context, and we can superimpose that onto what we're doing here in the emergency department, right? Particularly in the context of learning procedures, right? And this is where we're going to talk a little bit about how this applies to ultrasound-guided vascular access, but you can really apply it anywhere that you want, right? And so as an educator, what we're going to do is say, okay, I want to teach my residents, I want to teach my nurses, I want to teach my medics, whoever, how to do this thing, right? Use the ultrasound to put an IV into a vein, right? And do it successfully. And so the first thing that I need to do is identify the various different steps of that procedure, right? And we talked about this in the context of my dog, finding when he does the behavior that I want, reinforce that, now add in this cue, right? The same thing's going to apply here where I identify this procedure has step 1, 2, 3, 4, 5, break it down into component steps, and then identify those different, the psychomotor responses that I need to do, the mental map of the anatomy. And I can start piecing this back together and apply to that whole educational process either a positive, reward, like, hey, good job, or a negative stimulus of like, it didn't work out so well. And when we start layering on this, this positive reward, the affirmation, or when we layer on you actually are successful, right? Because that's a huge dopamine hit, a positive reward. All that reinforces what you just did. And so if we, again, take a step back from the theory of it and just think about it practically, we talk about doing a basic procedure like LPs, and they talk about you position the patient, you insert the needle, and you feel for the pop, right? And once you felt for the pop, then you get your CSF to flow out, and Bob's your uncle, right? You get your procedure done. And what you're trying to do is reinforce that I felt that pop and I know where I'm at. And then the CSF coming out is that positive reward that I got this thing to work, right? And so the more you do that, the more you'll notice the little subtleties and the nuances of all these different steps. And it's like, oh, there's that pop. And there's the pop, right? And that got me into it. And so as we break these procedures down, we need to start rewarding ourselves in some capacity with each little thing that we feel, we observe, each movement that we make to make this a successful procedure. So getting back to this list, we're going to identify the steps, the responses, make a mental map, teach where to puncture the skin, the angle of approach, how to move the needle, how to feel those tissue planes, and we want to apply this operant conditioning at each level of this. And so it happens in the context of these positive rewards or negative reinforcement where we don't get it. And then there's had that frustration of like, well, whatever I just tried didn't work, so we're not going to do that again. So let's, again, talk about this in the context of starting an IV, right? This is something that we do with ultrasound guided procedures, and we teach our people here to do that. And so the various different steps, I sat down last night and just kind of rehearsing, or putting the slide together, but thinking through it, you can break down an IV insertion, ultrasound or no ultrasound, into these various different components, right? You identify your puncture location through whatever means, right? Then you puncture the skin with the needle. You advance the needle through the subcutaneous tissue. You enter the vein, right? You adjust the angle of the catheter so you flatten it out to be more parallel with the trajectory of that vein. You advance the needle over the catheter, right? And once you've done that, you retract the needle, you have blood flowing from the catheter, you attach your tubing, and then you secure your IV in place, right? And so that's, if you want to break it down into the fundamental steps, these are the, 9 fundamental steps of putting in an IV. Now, the problem is when you teach someone going from like, I can't do an IV period to you're successful at it, the vast majority of the time to say that you're competent and you're skilled at doing it, there's a lot of trial and error as you're learning each one of these. Like you don't realize you're learning each of these 9 steps, but you are. Like you have to teach to each of these steps. You have to learn all of them and kind of learn the different, I need to enter the skin here. Like this is what I'm feeling for the surface anatomy. This is what it's telling me to enter the skin. Once I've punctured the skin, I need to know how quickly to advance through that subcutaneous tissue or how slowly to advance through it. I need to know what the different tissue planes feel like. And learning all that can be very, very challenging. There's a lot of sensory input that you don't really realize that's happening, but all of it comes into play. And so once you've learned that, once you've kind of isolated down what is successful, then it just becomes this this routine thing that you don't even, it happens in the background where you're like, oh, that just felt right. But you have to teach to all those different steps. And so the way to short circuit all of this, the way to make it faster, is to layer in the ultrasound, right? Because we can apply ultrasound to each one of these different steps and see how it improves our time to acquisition and time to teaching each one of these steps. So number one, you put the ultrasound down to just show where the vein is, right? The first thing you need to understand is, what does the anatomy look like underneath the skin? And so I can put the ultrasound down, I can scan it, I can see the vein runs from here to here, it's straight, it's this deep, it's this big, right? I can understand that very visibly with that ultrasound, right? And the second one then is to make that skin puncture, right? And you can see that you maybe not need the ultrasound to make the skin puncture, but you get underneath there. But definitely as you're advancing through the subcutaneous tissue, understanding what does your epidermis feel like, what does the dermis feel like, what does the subcutaneous tissue feel like, what does a fascia feel like when you're going through it, when I'm going to approach the vein, what is it, what's happening to the vein? Does it roll to the right? Does it roll to the left? What kind of technique do I need to do to capture that vein to get it to stick, so that when I make that final vein entry, what does that feel like? What does it feel like when it pops into that little give as the needle enters that vein? You can watch it happen with the ultrasound, right? And then the big critical step is adjusting that angle. So, I can't just like shove the thing down and keep pushing it in. It's not going to work. So I need that very nuanced understanding of like the hooking with my hand as I'm moving that vein, that needle from a very 45-degree angle to a very parallel with the vein angle. And I can use the ultrasound to watch all of that. And the point that I'm trying to make is, as we do that, we need to understand and feel all these different steps in our learning process. But the ultrasound, instead of having to figure it out by trial and error, and it's like, well, I guess it wasn't successful, we're able to visualize each and every single step, and allows us to progress through that learning process a whole lot faster, so that we need fewer repetitions to become very competent at what we're doing. And when we say fewer repetition, it has a secondary effect of then we have fewer patients that we need to puncture or to harm to be successful at the task that we're trying to do. And this is one of the arguments I tried to make in that subclavian line lecture, is as we're teaching people how to do subclavian lines, right, you're going to expect a certain number of complications. Theoretically, as we watch with the ultrasound, we can diminish, or we can decrease the number of patients that are going to suffer a complication by watching and being very specific and deliberate with our needle placement and understanding all that haptic feedback that we're learning and receiving as we're learning this new procedure. So that is it made it go live, but that is the first issue. And I think I put this slide up just to say, one of the things that I found with procedures that's very challenging is when we have to go through it without being able to visualize and do that trial and error and kind of that did work, that didn't work. If you don't get it right away, or don't start getting it right away, it creates this tension and this stress. And then that kind of turns into an aversion to doing the thing. And so my theory, and I was looking for some literature to back this up, so this is all just my opinion, but I think it's true, right? My theory is, if something is very difficult to learn, right, and your success rate is below a certain threshold, you're just going to give up. Right? You have to have a certain threshold. And I don't know what that threshold is, but you have to achieve success above a certain threshold for you to want to continue on to do this, to decide that this is worthwhile. And so I think ultrasound changes that threshold. It lowers it down so that I can be more successful more often, and then be better at the procedure that I'm doing. Honestly, this is why I do more ultrasound lines than peripheral lines, because I just have not gotten comfortable doing non-ultrasound guided peripheral lines. So anyway, that's reason number one. It decreases that time, or improves our learning, decreases that time that it takes to learn. Reason number two is, there are times when ultrasound is just the better test. Right. And yes, I know I am extraordinarily biased as someone who does point of care ultrasound, who's a self-declared sonophile, who likes ultrasound and does this as part of my practice. But there are times when it gives you a better answer than the other options that you have. And so there's a book that I read a couple years ago. I think I still have to finish a chapter 2 in this one. But this book, The Point of Care Manifesto, or the POCUS Manifesto, written by Larry Istrel, is a really, really good book. And it's kind of interesting. It's a hybrid book, right? It's in part textbook, because it kind of teaches you some of the stuff, shows you some of the data, but it's also written for just the consumer, like the physician consumer who doesn't know anything about point of care ultrasound, or just a person who's interested in something about medicine, about the history of how did point of care ultrasound come to be, right? And how has it been applied specifically in like cardiopulmonary applications, and how does it perform in some cases outperform other traditional imaging methods, right? And so they talked about a number of these big thoracic diagnoses and etiologies where point of care ultrasound outperforms. And so the first one is just an evaluation for pneumothorax, right? And so this is something we know as part of the FAST exam. We'll talk about it here coming up when we do the basic introduction to the FAST exam lecture. But you look for lung sliding, right? And it tends to be very, very sensitive for pneumothorax, right? It outperforms chest x-ray profoundly, right? The sensitivity is different studies show different numbers, but generally, in high 80% sensitive to rule out a pneumothorax, and about 99% specific to rule it in. It does, suffer 1% difference, loss to chest x-ray. Like if you see it on chest x-ray, it's there, right? Now the caveat to that is maybe you have someone with like bullous disease, like COPD, and so you're just looking at a big bullae. So you have to be very careful. I don't believe that the chest x-ray is 100% specific, but one of the studies said it. But that being said, point of care ultrasound is very, very good at showing showing pneumothorax. If you know how to look for it, some of the pitfalls and the nuances, it can outperform chest x-ray in many ways, specifically a supine chest x-ray that we so oftentimes rely on in the trauma bay. And so I've certainly had examples over the years where I've scanned someone and found pneumothoraces before we even got a chest x-ray, and even intervened without a traditional chest x-ray, because I knew that it was there. I knew it was big enough, and we were able to provide that service to the patient, right? So that's example number one. Another example they give in the book is pulmonary edema, right? So we know that ultrasound can do a good job looking for this interstitial thickening that happens as a result of pulmonary edema. And we've talked, last year we had a little mini series on thoracic ultrasound and how to use it looking at lungs. And we talked about how interstitial thickening can represent a number of entities, pulmonary edema among them, but it presents with these B lines, right? And the more B lines you have, kind of the greater degree of thickening that you have in your lungs and alveoli, right? And so when we look for this, if the clinical situation is right, you have someone who comes in, maybe a little bit, swelling all over the place, short of breath, got a history of heart failure. You see this thing, right? You see all these B lines. The sensitivity, specificity of point of care ultrasound significantly outperforms your chest x-ray, right? In fact, if you're like me, a lot of the chest x-ray reads that you get back are, we see some opacities in the lungs. It could be a number of things. We're going to list 3 or 4 of them in the impressions and say correlate clinically, which is code word for, you decide. You got the X-ray, you decide. But here we see that the sensitivity for point of care ultrasound is 97%, specificity 98% for pulmonary edema, compared to the chest X-ray that's in the 60s, for sensitivity. And so, again, another example where ultrasound, when applied appropriately, right, asking the right questions on the right patients, can outperform the chest X-ray. Same thing for a pleural effusion, right? A chest x-ray is decently insensitive and unspecific for a pleural effusion. It has to be decently big to be able to see it on a chest x-ray. But with point of care ultrasound, we can see very, very minute amounts of fluid. In fact, the question then is, at what degree do we start becoming concerned, right? Or are we seeing too much of this, or too little? And so is this clinically relevant? But it's a broader question to answer. But when you talk about pleural effusions, decently sized ones, point of care ultrasound is going to, again, outperform chest x-ray. And the final one to talk about is pneumonia, right? And I know that chest x-ray is the standard just because it's easy. It gives us a view of a lot of things. But if you look at the literature for pneumonia, point of care ultrasound, again, outperforms chest x-ray, specifically in the context of identifying pneumonia. So this is an example of a patient with COVID pneumonia. I know when the COVID outbreak happened, there was a lot of literature that came out about, hey, what does COVID look like? What does COVID pneumonia look like? On ultrasound, and there are a lot of protocols that people were putting out there saying, here's how we're using ultrasound to either assess for the primary assessment for pneumonia so that we don't have to expose our equipment and our extra technicians, or how to follow these patients with pneumonia as they're scanning. So you can see the pleural line, the kind of that shredding of the pleural line kind of in that middle section of the clip there. So, and again, Reason number 2 for today why POCUS makes you a better doctor is that sometimes it's just the better test. But to be fair, right, there's going to be the skeptics out there going to say, well, are there times when ultrasound isn't the best? And I think we have to be fair, right? We have to understand the test. We have to understand its limitations because, you can take a hammer and it works great for driving nails, but not so much for putting in screws or for doing other, carpentry related tasks. It doesn't cut boards very well. And so one tool isn't going to necessarily apply universally to everything. And so, yeah, there are times when ultrasound may not be the best test, right? And it happens basically when, there's some other tests sometimes that will outperform ultrasound or other indications or things that may affect the test that will allow ultrasound to not necessarily shine as it ought. So remember, we talked a lot about air artifact, right? That's going to obscure some things in the abdomen where, maybe a CT is the right answer, or maybe we need to have a broader understanding of all the organ systems together from an anatomic perspective, where it's going to not necessarily be the best answer in the moment. One of the classic examples I'll talk about where other tests outperform is in the assessment of trauma, right? And so we're going to talk about the FAST exam. Obviously the one of the birthplaces of bedside ultrasound is with the FAST exam, and it's a test that we hold near and dear to our heart. And there's been a lot of literature around the FAST exam, and when it's applied correctly, right, it actually performs really, really well. High sensitivities, good specificities, but the correct application is the key, right? So when the FAST exam is looking for free fluid and nothing else, great. But oftentimes what we want to know once we've done the initial assessment and stabilization of the patient are what are all the injuries, right? And so if we ask the ultrasound to perform, to tell us all the injuries, it's going to underperform, right? Because it's just not designed to look at all the possible things that could happen that are visible through imaging in the abdomen for patients who've been traumatized. And so this is an example of a study that was done. It's a systematic review and meta-analysis of pediatric FAST exams, and they were looking for intra-abdominal injuries, so all intra-abdominal injuries, and the sensitivity of ultrasound is about 30% in that context, right? Now, if you change that to what are the subset of patients who have free fluid and will it detect free fluid, that sensitivity is going to go way, way up. But if we ask it to do something that is not designed to do or not optimized to do, it's going to underperform for us and we're going to be disappointed. And then we're going to have all the naysayers say, see, told you your test is a load of garbage. And so I think it's important for us not only to say, can we apply ultrasound to this, but also to ask the question, what does the literature say? How has it been applied in the literature? And what are the limitations that this study may have, suggesting that it may not be the test for the moment right now? Maybe I need to turn to something else and get a different test. And so that's one of the things that I've learned over the years. When you go through training, you're like, hey, this is a cool test. Coming out, it's like enthusiastic, like it can do everything. And while that's not completely an untrue statement, as we learn more and more, as you do more and more ultrasound over the years, you'll understand, the limitations and say, okay, maybe it can't do this. Maybe I have to use it to answer a different question in a different way. And so I think, as we say, it is a better test in some capacities, right? So we talk about these cardiopulmonary etiologies. Another example that comes to mind is in the evaluation for small bowel obstruction. It outperforms all other forms of imaging. But if you're asking a question that is not designed to answer, like maybe where's my transition point? Or is there any injury to the mesentery for this patient? Perhaps it's not the best test and we need to reach for other things. And so don't close off your diagnostic options just because you like ultrasound, just because you listen to this lecture, and just because you want to promote the use of ultrasound more ubiquitously throughout healthcare. So that's issue number two, or reason number 2. The third reason that we're going to talk about today, why ultrasound will make you a better doctor, is that it allows you to narrow your differential diagnosis a lot faster, right? And so I ran into this graphic a number of years ago, and I was searching for it. I couldn't find it as I was putting this together, but it basically was a visual representation of this philosophy, or this idea that basically said, if you can come to the faster you come to a diagnosis for the patient, the correct diagnosis, obviously, and you can't just pick any diagnosis, but the correct diagnosis, the better the patient will do, right? And it showed like the improvement in mortality if you come to the diagnosis a lot faster. And if you delay in coming to the diagnosis, either for, because you can't figure it out, or the system's working against you, or it's just a really weird diagnosis that, is hard to find anyway, then, the patients tend to not do so well, right? And so when I was looking this up, a lot of the literature that I found surrounded, around this idea of like time in the emergency department. So if you delay patients getting out or getting up to the ICU, there's implications for mortality. And some of that, you'd have to extrapolate a little bit, but basically you can say, like, if it takes you longer to get to definitive care, whether it be diagnostically or structurally, patients aren't going to do so well. So as we try to understand this a little bit better and how ultrasound can maybe help bend this curve, let's think about the chief complaint of dyspnea, right? So a patient comes into the department. Again, the emergency department is a representation of undifferentiated healthcare or undifferentiated medicine. And so as we think about dyspnea, we can think of 1,000 different diagnoses for what's causing patients dyspnea. In fact, when I teach our residents or medical students on shift, they present to me a patient, and I don't do this all the time, but sometimes, the time is right, and I want to make the point, especially with the newer residents, of like, okay, you came to me with this chief complaint. Let's boil it down to one-liner. Here's what's going on. Now give me 5 reasons for why this is happening, right? And they'll give me 5 reasons. And I'll usually have a list in my head of my 5 reasons that I'm worried about. And if they don't hit all my 5 reasons, I'll say, okay, give me 5 more. And then they'll write down, 5 more. And usually they start struggling a little bit. And oftentimes there's one that I want to make the point about that's still not on the list. It's like, okay, give me 5 more. And, and obviously it's not malignant. Like, I'm trying to help them through this and, walk through a few of them with them. But what I want to show is, like, you're coming to me with a complaint of dyspnea. We can probably pretty easily come up with 10 or 20 different reasons for why a patient is dyspneic, right? Now, they probably hit the main reason in the first 2 or 3, but I want to show that we have a number of these. And so we got to weed through all these, because sometimes patients are going to come in with the number 19 or the number 20. And we have to somehow create structures in the way we think through patient care that allows us to get there and not prematurely close our diagnostic workup on 1 or 2 and just ignore everything else. And so as we think about dyspnea, a couple of things that come to mind, are, do they have a pneumo? Do they have a, pleural effusion? Do they have a pneumonia? Do they have a pericardial tamponade? Do they have, I don't know, we can come up with anemia. Do they have, all these other different, or pulmonary edema? Do they have pulmonary fibrosis? Do they have ARDS? Like all these different reasons for why a patient could come in dyspneic. And so as we think about it, a lot of these are scannable, right? And so here's an example. Top left, it's that interstitial thickening, right? And so depending on what the clinical presentation for the patient looks like, what their story is and what their past history is, this could represent their pulmonary edema, pulmonary fibrosis, interstitial pneumonia if it's focal, in its distribution. But there's various different things that this type of presentation will give us, as opposed to something which is completely, A lines, right? That's going to lean us more towards the asthma COPD portion of the dyspnea. That top middle, right? There's an example of tamponade, right? And if you're not thinking about it, you're going to be delayed in your finding this patient with tamponade. So think, are there cardiac reasons that cause this? And you use the ultrasound to look at the heart. Right? And the third one there, let's see if I can click on it here and get it moving. The third one here is an example of a patient with a pulmonary embolus, right? So if you're not thinking, if you look at the heart, you can say, hey, maybe this RV looks a little bit big. Do they have, there's that leg swelling. They have some pleuritic chest pain. So that's going to lead us down the PE route. And again, on the bottom here, we have an example of that COVID pneumonia, or like an atypical type pneumonia, and then a pneumothorax in the bottom middle. In the bottom right, we have that pleural effusion. Again, all of these present with overlapping clinical presentations, but they all have very distinct, they all have very unique, and they all have very different management strategies, right? In fact, they have different places that you're going to go in the hospital to be managed, right? There'd be the floor versus the ICU versus, the cardiac service versus the medicine service versus the, somewhere else, right? Interventional radiology, whatever the case may be. And so since all of them have different things that need to be done, the faster we get to the most appropriate diagnosis, the better the patient's outcome is going to be, especially with the patients in the middle there with the tamponade or the tension pneumothorax. And so ultrasound can really help us in this capacity and others to really narrow that differential diagnosis more rapidly. As we thought of that list of 10 or 20 things, we can shorten that up very, very rapidly and get us to a very targeted list of things with that ultrasound. So to reinforce that point, here's an interesting study that I was looking up last night. Basically, they're looking at point-of-care ultrasound application in the setting of dyspnea, right? So kind of this patient cohort that we're talking about. And what they did is they said, hey, look, if we apply this ultrasound right away, right, the moment the patient hits the ED versus, let's let the providers get a workup going and we'll get to that ultrasound a little bit later. What is the concordance with the ultimate end diagnosis, right? And I think it's interesting implications for this idea of, can we short circuit a lot of that diagnostic process by just looking, right? And if we can get there faster, can we help these patients a little bit faster? Can we help our workflow in the department a little bit better? Can we get people through the department a little bit faster? And so what they found is that for the immediate POCUS group, right, this is going to be the left-hand side of this flow chart, had a greater concordance with the final diagnosis than the patients who they basically, or the providers, they said, okay, do your thing for a little bit, get a few tests, kind of what are you thinking now? Okay, now let's apply the ultrasound. Now what do you think, right? Having that more broad shotgun type approach led to a little bit more range in terms of what the providers, were thinking, and it took them a little bit longer to get to the ultimate final diagnosis than the patients who the providers like, just look, short circuit this whole thing and just look. And so I think it's interesting. Again, certainly it needs to be applied in the right contexts, but it's an interesting way of thinking through how can we use ultrasound a little bit closer to the front end of our patient care to really start narrowing down on how or on what's going on with the patient and how we can manage them. Another example I can think of, I didn't put it in here, but one of our colleagues, Dr. Mersch over at University of Buffalo, has talked about is can we apply ultrasound in the right upper quadrant, maybe even in triage for these patients with upper abdominal pain to really narrow in on you got gallstones, let's start heading down that route versus I don't know, it could be a bunch of things. Let's get a CT and find out. So various different applications. If we think about it, we could probably come up with some more. So just by way of review, as we introduce kind of grand rounds for this new academic year, we talked about more reasons, 3 more reasons specifically why ultrasound can make you a better doctor, right? And those are, it improves our test, or it's better test characteristics than certain other applications. It improves our ability to learn, right? And short circuits a little bit of that operant conditioning loop that we need to go through as we're either teaching or as we're learning different things that are highly technical, that require a lot of eye-hand coordination. And it also helps us to more rapidly narrow that differential diagnosis to ultimately get to the answer that we need for our patients a lot sooner. And so with that said, we're looking forward to doing more of these over the course of this next year, talking about how ultrasound can really make an impact in your practice. If you want to go back and learn more about what we've done over the course of previous years, kind of learn about all the things we've done, I would encourage you to head on over to the YouTube channel, MetroHealth Emergency Ultrasound. We've got a lot of great material up there from a lot of great people, Dr. Shaman, Dr. Anisha, Dr. Sid from CCF, among others, talking about various different aspects of bedside ultrasound, how we can use it to make ourselves better as providers, but also improve the care that we have for our patients. But thank you guys for joining us again today and again for this next season. I'm looking forward to bringing a lot more of these to you guys. It's been a great opportunity to just kind of dig in and kind of research some things I'm interested in, but also rehash some of these other topics and make sure we have some good material out there for you guys to look at. So go check it out, MetroHealth Emergency Ultrasound on YouTube. Come back the same time, same place, same Zoom link. We're going to do it every other week moving forward here for this academic year, just so we can make sure we get some priorities here at home accomplished, but we can still bring all this good information to you. So we'll see you guys later.